I'll write a little bigger. Okay, everybody, thanks for coming to the lecture. So what I thought I would do today was start at the beginning and just review a very basic approach to acid-base diagnosis. So we're not going to talk about all the panoply of diseases that affect the acid-base status of blood. Simply, how do you approach these numbers and where do they derive from? So on the top line, represents the bicarbonate buffer system, and I don't know how clear it is on the video, but what it says is that carbon dioxide and water combine to form carbonic acid, which then generate a proton and bicarbonate, and the bicarbonate can further break down into another proton and carbonate. So when we're evaluating the acid-base status of blood, we're actually referring to this reaction. Now, we don't have to. We could be talking about albumin and a proton making protonated albumin. There's many buffers in the body. But this is the most prevalent buffer, plus the fact that the acid form is volatile. So the carbon dioxide is called an acid anhydride because when it reacts with water, it forms carbonic acid, but it's volatile, it's in the gaseous form. And so our lungs affect the acid-base status of blood too. So for a number of historic reasons, this is what has been analyzed over time. The next important point is that you can't measure bicarbonate. We can only measure the total CO2, and a lot of clinicians call what they get back on the chem panel bicarbonate, and it's not. It should be called the total carbon dioxide content of blood, and it represents a number of different forms, actually. It represents bicarbonate. It's mostly bicarbonate. But there's also carbonates being measured, and there's carbonic acid, and there's dissolved carbon dioxide. So because the total CO2 represents mostly bicarbonate, these have been erroneously equated with each other. So if this is, let's say, 25.5 millimolar, the bicarbonate is 24 or 24.5. Oh. The big difference is the dissolved carbon dioxide between the total CO2 and the bicarbonate. So the dissolved CO2 represents carbon dioxide that's dissolved in blood, and you can calculate that because it's 0.03 times your PCO2. So if your PCO2 is 40, the dissolved carbon dioxide represents 1.2 millimoles. But if you have a respiratory acidosis and the PCO2 is 80, then it represents 2.4 millimoles per liter. And you can see that the discrepancy between the total CO2 on the chem panel and the actual bicarbonate is going to get more and more and more and more as the PCO2 increases. So that's an important point because you can have a big difference between these two with people with severe respiratory acidosis, and they get closer together as the PCO2 decreases in respiratory alkalosis. So definitions are important, and from now on, when you get the chem panel back, don't call it bicarbonate, call it total CO2. Now, it turns out that the important players here can be equated in what's called the Henderson equation, or it's a modified form of the Henderson equation, which doesn't have to have these acids and bases. It can be any acid and base, but because these are the parameters we analyze clinically, those are the parameters that are in this equation. What it says is that the free hydrogen ion concentration is equal to 24, which is a constant. That number doesn't change, times the partial pressure of carbon dioxide over the bicarbonate concentration. And looking at these numerically, you can see that the right side equals the left side. This is 40. The units don't match, but the absolute value of the numbers match. So the hydrogen ion concentration is about 40 nanomolar in a normal human. And that's equal to 24 times the PCO2 of 40 over a bicarbonate of 24. So the right side always equals the left side. And the other important point about this equation is it's true no matter whether you have an acid-base disorder or not. So no matter what the absolute numbers here, the right side must equal the left side. So what the pH meter does, or what the machine does, where you send an acid-base assessment, there's a pH electrode that measures this, and there's a PCO2 electrode, and the machine has this equation on its chip, so it calculates the bicarbonate. You never get back, as I said, a measured bicarbonate. There's no bicarbonate electrode or assay for bicarbonate. What we measure is the total carbon dioxide content of blood, and normally when this comes back, you can compare it to this, and this should be a little bit more than this. This can never be more than the total CO2. If it is, there's something measured incorrectly. Now the problem is to put numbers into this equation. We don't get back hydrogen ion concentration. We get back pH, and we can thank Sorensen for that. It was 1916. They decided, unlike other ions, that we'll use the negative log of that concentration. So we don't do it for sodium, we don't do it for potassium, and there's a thermodynamic reason we do it for hydrogen ions, and that's because the voltage on the pH electrode varies with the pH linearly. It doesn't vary with the hydrogen ion concentration. And the other reason clinically is that clinicians hate a lot of decimal points, so they don't like walking around saying my patient had a hydrogen ion concentration of 40 times 10 to the minus 9. So there's a human reason because of the large number of decimal points, and there's a thermodynamic reason. So what evolved was to use pH, and because of that, what do you do with this equation? You have to be able to convert pH to hydrogen ion concentration. Now there's a simple way to do that. If you just remember that a pH of 7 is a hydrogen ion concentration of 100 nanomolar, and then what you do is you just write down 7.1, 7.2, 7.3, and you just take 80% of the previous number. So a hydrogen ion concentration of 7.1 is 80, 7.2 is 64, 7.3 is 52, 7.4 is 40, and you can interpolate in between. It's pretty linear. So once you have the pH, you then convert it to the hydrogen ion concentration and plug it into here, and then put in the patient's PCO2 and the calculated bicarbonate. You can just check the equation. You can put the total CO2 in here also. It'll be a little bit off. Okay. So there's a couple of other subtleties, and the next subtlety is that male and female values are not the same. Everyone assumes that the hydrogen ion, that the PCO2 is 40 in all humans, and the bicarbonate's around 24 or 25, but that's only true of males. If you look at a population of women, the PCO2 is lower. It's about 37, and the bicarbonate's around 23. And you have to know this because the thought process that you go through when you're analyzing acid-base disorders is really always looking at what the patient has versus normality. So you have to know what normality is. So the normal values in females are different, and that's typically ignored. And also, when a woman ovulates, the PCO2 drops. And in fact, that used to be used as an indirect assessment of what the PCO2 was. So the PCO2 drops. It can drop to, in the high 20s at mid-cycle. And that's due to the effect of progesterone on the ventilatory system. And there's changes that occur throughout pregnancy, especially in the third trimester of pregnancy, which I'll show with one of the patients. So women don't only have lower numbers, but it changes throughout the month. Now the other difference is AV differences. It's always a question, should I do venous or arterial blood gases? And the answer is that in most clinical situations, you don't care what the arterial is unless you want to know what the PO2 is for something. Venous is fine. And when you look at the numbers again and compare the artery to the vein, if the PCO2 is 40 in the artery, it's around 43 in the vein. And if the bicarbonate's 25 in the artery, it'll be about 26 in the vein. And the pH, let's say it's 7.4, is going to be a little bit lower in the vein, 7.37. So we're talking about subtleties here, and certainly nothing that's clinically going to alter your diagnosis. Now, there are clinical situations where the arterial and the venous blood gases have different acid-base diagnoses, and there what you should be doing in the chart is putting down the diagnosis for both types of blood. So there are patients that have respiratory arrest without a cardiac arrest, and they can have very different arterial venous blood gas differences. In fact, it's the PCO2 that differs the most. As the cardiac output decreases, you get a bigger and bigger difference between the AV PCO2 difference. In fact, people used to use that in the 50s to assess the cardiac output or have a rough indication of the cardiac output. So we don't need to go into detail with that, but just to know that there are some clinical situations where the arterial and the venous numbers are different. So in most situations, patients with normal cardiac output, you can assume that they're the same and you can interchange them. In fact, people used to talk about arterialized venous blood gases, where they don't do it anymore, but there used to be this glove in the hospital that you put the hand in, and you have a little hep lock on the back of the hand, and you increase the flow so much because of the temperature that you actually get arterial numbers in the vein by increasing the flow so much. So there's a whole literature and arguments back and forth what you should use, but the bottom line is you can use both. Now the one problem is when you're assessing this equation, right? Oftentimes you mix the different types of blood, which can be a mistake. So the hydrogen ion and the PCO2 might be from arterial blood, right? If you got an arterial blood gas, but this might have been, or the total CO2, which is a reflection of that, might be from venous blood. And there, you're mixing two different types of bloods, and the numbers may not work out. So in general, if you're checking this equation, which again is valid no matter what the acid-base disorder is, make sure it's the same type of blood. And if your patient does have a cardiac output problem, make sure you get, and you're interested in the acid-base status, make sure you get both types of blood. Are there any questions about that so far? So remember AV differences and male-female differences. Any questions at all? Okay. Okay, so again, we'll go back to the modified Henderson equation. Remember, it's true for any type of blood, no matter what the acid-base abnormalities. So the problem is that it's a dynamic situation. We're not taking a picture. There's a movie going on. We have an input of this from all our cells. Mitochondria are making carbon dioxide continuously. So all the cells in our body are making about 13,000 millimoles of carbon dioxide a day. It's a lot of carbon dioxide. And obviously, if this number is staying constant, we must be getting rid of it. So that's the function of our lungs. Our lungs get rid of that amount of carbon dioxide every day. And if we have a discrepancy, then we have a respiratory acid-base disorder. We change this number. So as long as the production and the excretion is the same, this number will stay the same. But we have the same problem with bicarbonate. Every day, our diets make protons in the form of hydrochloric and sulfuric acid. And so something else must be occurring, otherwise this number in a couple of weeks will go to zero. So we have a carbon dioxide load, which our lungs get rid of, and we have a proton load from our diets, unless we're only eating lettuce all day. Assuming we're not extreme vegetarians, we're generating protons, and they have to be gotten rid of. So it turns out that that's the function of the kidney, and the kidney, we won't get into that today, but the kidney actually doesn't get rid of the protons. It actually generates an amount of bicarbonate that is equal to the bicarbonate that was consumed by that. So the kidney actually generates bicarbonate to match this daily proton load. And so that's how this number stays the same. Now, there are other subtleties that occur here that I'll talk about if there's time. So that's how these numbers stay the same. And acid-base disorders occur when you get input-output inequalities of these two things. Now, the problem is because they're in equilibrium, when you change one of these in the solution, the other one changes. So that's the complexity here. If you have a proton load, that proton doesn't just combine with bicarbonate and lower it. It actually forms carbonic acid, which will then make carbon dioxide and water. So we have something else occurring here. Now the carbon dioxide we get rid of, let's say this was lactic acidosis or ketoacidosis, and we have normal lungs, we just excrete the carbon dioxide. And vice versa, if you decide to hold your breath now and this goes up, you're going to send the reaction the other way and you're going to generate bicarbonate. So that makes it more complex in that we have these external whole body input-output issues, and we have this equilibrium that occurs in the solution that shifts things back and forth. So it's a small miracle that anybody ever figured out the cardinal acid base disorders and what to do. And it's really in the 1960s, Schwartz and Relman in Boston that really came up with the way we now approach these disorders. Now, the other thing I didn't mention is that in addition to the kidney having to match the daily hepatic proton load, the kidney also has to reclaim all the filtered bicarbonate coming through here. Because remember, there's about 150, or let's say 150 liters per day going through all your 2 million glomeruli. But in each liter, you have 25 milliequivalents of bicarbonate. So if all that was peed out, your bicarbonate would go to zero in 4 hours if you do the math. So it turns out that the nephron must reclaim that bicarbonate. That's roughly the amount of bicarbonate in a box of Arm & Hammer baking soda. So when you look at your shelf tonight and you look at that box, that's about how much bicarbonate comes through all the glomeruli in a 24-hour period. But the nephron must reclaim that to keep the bicarbonate at 25. In addition to making new bicarbonate to match your dietary hepatic proton level. Are there any questions about that? No? Totally unclear? Okay. So with that little background, let's now look at how your brain should approach these numbers when one of them is perturbed. So there's a number of different approaches, but I've just found over the years this is the simplest. And what you focus, so you have a whole bunch of numbers. The question is what to focus on. It can be overwhelming. And what you should focus on is the total CO2, or we'll call it bicarbonate. But it could be the total CO2 from the chem panel or the bicarbonate, calculated bicarbonate from the blood test. And you ask the simple question, is it normal, decreased, or increased? Okay, so let's say it's decreased. And then you have to say, what are the acid-base disorders that decrease the bicarbonate? And it turns out there's 3 that cause it to go down, and there are 3 that cause it to go up. So the easiest one is metabolic acidosis that everybody knows. But there are 2 other acid-base disorders that lower your bicarbonate, and they're the respiratory acid-base disorders that we divide up temporally. We don't divide them up by anion gap or chloride sensitivity. Well, it's historic. We could call it compensated or not compensated. We never use the word compensated in respiratory acid-base disorders. So we divide up the respiratory acid-base disorders by acuity or temporally. So there's acute respiratory alkalosis would be a cause of why the bicarbonate fell, or chronic respiratory alkalosis. Okay, so in all 3, the bicarbonate goes down. And then, conversely, there's 3 reasons why the bicarbonate can go up. You have metabolic alkalosis, which everybody remembers, but you also have 2 respiratory acid-base disorders. There's acute respiratory acidosis, and there's chronic respiratory acidosis. So we have really 6 acid-base disorders that we have to think about, but only in a given situation, assuming it's a pure disorder, only 3. So let's look at the decreased bicarbonate first. And how are we going to distinguish between these possibilities? And that's the next trick. So the first is, again, just to recap, look at the bicarbonate, decide is it normal, increased, or decreased, and if it's decreased, then you write down the 3 possibilities. And don't just write down respiratory alkalosis, divide it up temporally. So again, drop in bicarbonate, and it's either metabolic acidosis, acute respiratory alkalosis, or chronic respiratory alkalosis. And the way we distinguish these 3 possibilities is by looking at the ratio, and this is a little bit of a harder concept, but we look at the ratio of the change in bicarbonate or total CO2, assuming they're close to equal, to the change in the PCO2. We do not look at the pH. Okay, if you look at the pH to diagnose acid-base disorders, you're going to miss mixed acid-base disorders, which I won't talk about today. But you never have to look at the pH with this approach. So try to cover the pH when you're doing it. Okay, because your brain will go off into different directions, and you really will miss mixed disorders. So you just go to this next simple thought: what is the change in the bicarbonate versus the change in PCO2? And the reason for doing that was empirically known since the 60s, that each of these has a different change in each, a different proportion. So that's the memorization part. You have to know what these things should do for each of these three disorders. So in metabolic acidosis, for some reason people love the Winters formula, but you can forget it because you don't need to know it. And in all of these, we're actually looking at just the slope of the relationship. You don't need to know the intercept. And so for metabolic acidosis, it turns out that this is around 1 to 1, if you want to think of it like that, 5 to 5, 10 to 10. But the concept is that in metabolic acidosis, whenever you drop the bicarbonate, you get an additional change in the PCO2, and the change in both are equal. So that's the first rule. If you have a drop in the bicarbonate and you then look at the PCO2 and you see that the change in the PCO2 is the same as the change in the bicarbonate, that must be a compensated metabolic acidosis. There's nothing else it could be. You will not get that proportion in acute or chronic respiratory alkalosis. If it's acute respiratory alkalosis, what you find is that for every 10 change in the PCO2, the bicarbonate drops about 1.5. So there the cause and effect is switched. So here we have a drop in bicarbonate, but not because of loss of bicarbonate or proton load or anything affecting the bicarbonate per se. Here we're changing the ventilation, and then that shifts to equilibrium in that bicarbonate buffer reaction. It has nothing to, acute respiratory alkalosis has nothing to do with an organ. So if we just look at this reaction, whenever we change the PCO2, we shift this. Here we're dropping the PCO2, so everything just shoots that way. It's like opening a bottle of Coca-Cola. You have carbon dioxide and bicarbonate inside. As soon as you open the cap, you lose carbon dioxide, but you're also losing bicarbonate if you can measure it. And the relationship is known that for every 10 millimeters of mercury fall in the PCO2, this will shift such that the bicarbonate will fall 1.5. You don't need any organs for this. This would occur in solution with the same buffer capacity. It wouldn't be exactly the same. But if you took blood out of the body and removed the carbon dioxide, you'd get roughly this. I mean, there's intracellular buffering too, so it's a little more complicated. So let's just do this temporally now. Let's look at the PCO2 and the bicarbonate. And let's say, for some reason, you started to hyperventilate and you kept your PCO2, which was normally 40 at 30. If you were tracking the bicarbonate with time, you'd find it would fall about 1.5 acutely, and that's what acute respiratory alkalosis is. But if you kept the PCO2 at 30, you don't change the PCO2, and you kept measuring the patient's bicarbonate every day, you'd find that after about 5 days, it fell further. And it turns out it would fall another 3.5, so that the total fall would be 5. After about 4 days, you reach a new steady state, and that we call chronic respiratory alkalosis. We don't have a name for everything in between. Obviously, it's dynamic. So we just talk about the acute initial change and then when we reach a new steady state. But if you're catching the patient in between here, you're going to get numbers in between. It'll be between the full 5 and the 1.5 change. Okay. So the question then is, why does it fall a further 3.5? That can't be that can't be this equilibrium. That occurs immediately in solution. This requires the kidney. And it turns out the kidney actually isn't dumping bicarbonate. If you measure the bicarbonate in the urine or the urine pH, you find hardly any bicarbonate. It actually occurs because the kidney shuts off its new bicarbonate generation that I was talking about before. I won't get into how that occurs, but the kidney is actually changing its production of new bicarbonate. It's not a bicarbonate reclamation problem like RTA. You don't find bicarbonate in the urine. Very little. Okay, so let's say we have a patient with a PCO2 of 30 and a bicarbonate of 15, right away you look at those numbers, assuming normality, you know they're roughly equal. That can't be anything other than compensated metabolic acidosis. You don't have to look at the pH. Whereas if someone had a PCO2 of 30 and a bicarbonate of 20, that can't be metabolic acidosis compensated, right? Because the ratio is 2 to 1. And it only fits with the chronic respiratory alkalosis. For every 10 fall in the PCO2, the bicarbonate falls half of that. And if the PCO2 was 30 and the bicarbonate was 23.5, that's acute respiratory alkalosis. So again, we've done this without looking at the pH at all. So you just have to memorize what the expected changes are for each of these cardinal acid-base disorders, and then see what does my patient have. Now, if it's neither of the three, then there's a mixed acid-base disorder. We won't go into that today. But if it falls into one of the three, that's the acid-base disorder. Okay, so the respiratory alkalosis and acidosis are complicated because there's, after the initial change in the PCO2, there's a dynamic change in the bicarbonate, unfortunately. So you have to wait till a new steady state is created. We do not call this, by the way, a compensated respiratory alkalosis. You don't use the word compensated in the respiratory acid-base disorders. And you could say, why not? And the answer is just for historic reasons. There's no rationale for it, other than the fact that the word compensated sort of implies that you're bringing the pH back to what it should be. And there's a whole slew of papers and arguments suggesting that these changes, secondary changes, are not actually bringing pH back to what it should be extracellularly. It might be intracellular. So people have gotten away from the word compensation, other than in the metabolic acid-base disorders. Okay, so we have this distinction for respiratory acid alkalosis into acute and chronic. We don't divide metabolic acidosis up temporally. We divide it up by what? Nothing fancy. How do you divide the metabolic acidosis up? Yeah, the anion gap. Okay. So the anion gap, we calculate very simplistically, and that's just because we don't want to measure everything. So it's sort of correct. We take the sodium minus chloride plus, and it's a question that some people ask, should I put bicarbonate in here or the total CO2? And actually, it should be the calculated bicarbonate from the blood gas, because the total CO2, remember, can include 0.03 times your PCO2, which is not charged and shouldn't be in here. And people often put the total CO2 in here, and especially if you have a big discrepancy between the two because of a marked elevation in the PCO2, you're going to even be more wrong. So try to put the bicarbonate in there if you have it. If you don't have it, well, you put the total CO2. But in fact, this just reflects a phenomenon in all solutions in our body, and that's that we have electroneutrality. So the sodium plus potassium plus calcium plus magnesium equals the chloride plus bicarbonate plus the charge on albumin plus the charge on other organic anions. So in reality, when we take this and subtract these two, we really are left not just with anions that we're not measuring, which is albumin and other organic anions floating around, but we really are looking at the charge on albumin plus organic anions. You can include phosphate in there too. Minus the calcium and magnesium. So you can see that there's many things that can affect the anion gap, and it's important in different situations clinically. For instance, if you have a patient that's markedly hypercalcemic, that lowers your anion gap. Or if you have a patient with a low albumin, that will lower the anion gap. You see? So it doesn't just reflect organic anions floating around. Most of the time it does clinically, but in reality, there are many things that can affect it. So again, it's just a reflection of the electroneutrality. And we simplistically only look at 3 of the players here, when in fact, ideally, you should be measuring everything to find out what is causing the difference, but you just don't do that. And there's two other subtleties, and that is that, especially with, as far as the clinically important concept, and that is that albumin doesn't stay the same. So it turns out from a number of different papers that the albumin actually contributes 11 milliequivalents per liter to the anion gap. And you can say, well, how's that possible since the anion gap is around 11? And that's because of all the other things that were not included, the calcium and the mag and everything else. But when you plug all the numbers in, you will get a difference of, about 11 for albumin alone if you measured everything and then subtracted everything from everything except albumin. Okay, you get an answer of 11. The other important point is that changes in the albumin change the anion gap, and that's important clinically. So, and it's known that for every 1 gram per deciliter that the albumin changes, the anion gap changes by 2.5. That's a lot. So if your patient's albumin is 3, your normal anion gap would be around roughly 9. If your albumin is 2, it'd be 5 lower than you'd expect. So that's important because if you have someone with an albumin of 2 and they have an anion gap of 6 or 7, that's normal. If their anion gap's 11 or 12, you have to start thinking of an anion gap metabolic acidosis possibly. So you have to, when you're approaching the patient and you're saying, is their anion gap normal or abnormal? Well, you have to know what the normal should be for that patient, not what the normal is for the population, because the population assumes the albumin is 4. So especially a lot of our kidney patients, from PD, patients from PD, these kind of things, or nephrotic syndrome, liver disease. We have a lot of patients with abnormal anion gaps here only because their albumins are low. Oh, the other thing is that the pH affects the anion gap because it titrates phosphate and it also titrates albumin. Albumin is a base. And there are a lot of, there's a net, if you look at all the amino acids that are charged, glutamate, aspartate, arginine, and lysine, there's net negatively charged amino acids, and there's a certain net average pK. And it turns out that you have to think of albumin as something that can bind protons and release protons, or if you want to call it a buffer physiologic pH. But pH affects the protonation of albumin. So if you have someone, for whatever reason, whose blood is acidemic, that's going to lower the anion gap, just acidifying the blood, for whatever reason. And if you increase the pH of the blood, and the blood's alkalemic, you're going to raise the anion gap. So anyone with a metabolic alkalosis has a slightly higher anion gap than normal, not because they have an anion load, just because you've titrated albumin. So you have to think of the effect of pH per se on the charge on albumin. And it turns out people have done different studies, but in some of the papers they say it's about 0.5 change in the anion gap for every 0.1 change in pH. So if pH goes from 7.4 to 7.5, that's going to make the anion gap go up by 0.5. If the pH goes from 7.4 to 7.6, the anion gap will go up by 1. It's not a huge effect, but it's just something to consider. Okay, so the other important thing about the anion gap is, again, unfortunately, like the PCO2 and bicarbonate, we have a dynamic situation. We don't just have a box with solutions in it. We have a human body with an input and output. So let's say you have a patient who got ketoacidosis. Okay, well, you have a proton coming into the box, coming in with ketone bodies, beta-hydroxybutyrate, acetoacetate. And we tend to, when we're residents, or maybe before that, think that that's all that occurs. But when you become a renal fellow, you start thinking, okay, there's outputs too. And it turns out that these organic anions can be excreted from the body. The proton, as I mentioned, is a bit more subtle. We actually don't excrete protons. We generate an amount of bicarbonate. The kidney generates an amount of bicarbonate equivalent to that. The bicarbonate proton is already bound to the bicarbonate and destroyed it. But at any rate, there's a balance again. The concept is there's an input-output. And so it's a common question. When you have someone with ketoacidosis, how is it possible to have a normal anion gap? and that comes up clinically. And the reason is the anion gap just depends on the concentration of these two substances in the blood. And if from time zero you were excreting it, you're going to have the metabolic acidosis from the proton load, but you're not going to have an elevation of your anion gap because you've excreted the anions in the urine. So you have to look at the urine for organic anions, but you're not going to find it in the blood. Same concept as having a patient with a sarcoid or someone with a calcium load, whatever reason, but you're not hypercalcemic, you're hypercalciuric because the kidney is getting rid of the calcium at the same rate it's going into the body. It's the same concept here. When you think about it, the anion gap can be whatever you want. There's no correlation between the input of organic anions and what the blood level will go to unless you have no output, unless you have ESRD or something, and you have no way to excrete the organic anions, then every organic anion that went in will be in the body. But in someone with kidney function, there's an excretion rate. So you can't look at the organic anion concentration or the anion gap concentration as a reflection of the severity of the ketoacidosis like people do. What you really want to know is what's the excretion of the organic anions in a time collection. That would be a reflection in the steady state of the production rate. Now the other problem is people talk about delta gap. Has anyone heard of that? The delta, okay. And there's a problem with that too. So what people do is they go, oh, the anion gap went, let's say, from 10 to 15, and my patient's bicarbonate now is 25. So I'll take the difference between this, which is 5, and add that to the current bicarbonate to get what the bicarbonate used to be. And that would be fine with two assumptions. One, that there's no output of these things. And secondly, they both went into the same space. So if you did this on the bench, this would be true, that for every fall in the bicarbonate, the anion gap must go up by the same amount. But because we have a dynamic system with an output of each, and because, which I didn't mention, the volume of distribution of these things is different, it turns out. So the organic anions only stay in the extracellular space. So when you get ketones coming in or lactate, they only stay in the extracellular space, predominantly. They don't go in the cell. So they change the concentration in that solution, whereas the protons go throughout your whole body. And 60% of the protons actually go intracellularly or buffered in the cells. So the bicarbonate is not going to change by as much as you would have expected had the protons stayed in the extracellular solution only. So the change in the anion gap for equal input is always greater than the proton load, even in the patient with ESRD, because the anions only stay in the ECF, whereas the protons go into a much bigger volume. So that's another reason why this delta-delta story can never really play out in the real world, even though certain people love asking renal fellows that question. And also you'll see it on exams. But in the real world, it's a bunch of baloney. But it makes people feel like they're calculating. Okay. So remember that the anion gap's dynamic. It's very important. The organic anions have an input and output. And remember also that it's affected by your acid-base status and albumin concentration. One other point is that the volume of distribution of proton or bicarbonate can be calculated. So it's 0.4 plus 2.6 over the current bicarbonate times your lean body weight. I mean, this is a horrific thing to remember, but you can look it up. So the volume of distribution of bicarbonate is 0.4 plus 2, let's say this is a tenth. So it's 0.5 times your lean body weight. Let's say your lean body weight is 70 kilo. The volume of distribution of bicarbonate would be 35 liters. So you need to know that because oftentimes it comes up therapeutically, how much bicarbonate should I give? And the point is, that, well, the next question is, well, what volume are you putting it into? And so this helps just because people don't have the same lean body mass, but it's more importantly important because it varies with what the bicarbonate concentration is. That's the horrific thing clinically, that as you lower the bicarbonate concentration or you have a more severe metabolic acidosis, when you do the math, the volume of distribution actually gets more and more and more because more and more is buffered in the cells. So you have to give more bicarbonate. So as this falls, you're going to get a bigger number here for the volume of distribution. So it's important just because of the difference between people and also because of the difference in the severity of the metabolic acidosis, you'll see you'll need more bicarbonate. And that also affects the difference between the change in the anion gap in it. So as the metabolic acidosis gets more and more and more, the volume of distribution of the proton and bicarbonate get more and more, but the organic anion still stays in the extracellular fluid. So the delta-delta gets more and more and more discrepant. Okay, let's do some numbers. Okay, so here is a 27-year-old female with these numbers. So the sodium is 131, potassium 4.5, chloride 95, total CO2 15, BUN 30, creatinine 1.4, and the blood gases, the pH is 7.32, PCO2 is 28, and the bicarbonate is 14. Does anybody want to tackle that? So again, yes, the patient's got a dysmenorrhea, but remember, and there's some renal insufficiency there, maybe pre-renal. But look at the total CO2 or bicarbonate. So the first question is it normal, up, or low? And you can use the total CO2 or bicarbonate. You see here they're almost the same. The total CO2 is a bit higher, again, because this includes some dissolved carbon dioxide. So does anybody want to take a stab at it? These are not, yeah, it's low. Okay, so the bicarbonate is low. So what are the three acid-base disorders that lower the bicarbonate? Okay, very good. So then you look at the PCO2, and now you calculate the change in the PCO2 from normality versus the change in the total CO2 from normality or bicarbonate. And remember, this is a female, so don't use 40 for the PCO2 and 25 for the bicarbonate. You have to lower the numbers. So take 37, 38 for the PCO2, let's say 38. And this is around 23, 37, whatever. So what's the change in each, roughly? What's the change in the PCO2? Yeah, 9 or 10. Unfortunately, you never know normality, so you have to assume population normality, which is a problem unless you have previous numbers. And what's the change in the bicarbonate or the total CO2? Just roughly. We don't know the original either. Yeah, it's roughly the same, right? So this can't be acute or chronic respiratory alkalosis. It's only compatible with what we call a compensated metabolic acidosis. Now, another point which I didn't mention is if you know with metaphysical certitude you have a metabolic acidosis, let's say you injected the protonated lactate into a patient. So you know that the bicarbonate must have fallen from a proton load, but then you look at the PCO2 and it hasn't fallen what the bicarbonate fell as predicted. The lack of the appropriate compensation means you have a mixed disorder. And that also means that you have a respiratory acid-base disorder. So it's an important point that if you know there's a metabolic acidosis and the compensation isn't what you'd expect, by definition you have more than one acid-base disorder. And in this context, you must have an additional respiratory acid-base disorder. So for instance, if the PCO2 here was not 28, if it was 40, this patient also must have a respiratory acidosis, even though it's 40. And if the PCO2 was 24 or 23, below 28, there's a respiratory alkalosis. So the 28 becomes your new norm. That's the key conceptual point here. Okay, and then this patient, okay, let's say the patient's blood sugar was 600 here, and the patient got volume, so someone started normal saline, and the new numbers are these. Oh, what was the anion gap here? Again, your first question is, should I use the total CO2 or bicarbonate? Right? Always ask that from now on. And ideally, you would use this, but let's say you didn't have blood gases. Let's say you only had this. You can assume it's one higher than the bicarbonate if someone's ventilation is normal, right? Because 0.03 times this is around 1. It's always around 1, what the carbon dioxide contributes to it. Remember, the dissolved carbon dioxide plus this is equal to the total CO2. So this is around 1, this is 14, that's what you get 15. So let's say you didn't have the bicarbonate, you would use this. What's the anion gap? I am asking you, I can't calculate it that fast. Okay, so it's around, I don't know, 10, 11 higher. If you go up to 15, it's 6 higher. We don't know the normal, unfortunately, but let's assume it's in that range. And now the patient got volume, and these are the new numbers. So the total CO2 stayed about the same. The renal function improved a little bit. So this is like it was pre-renal. And the anion gap now is 9. So what's going on here? So, and we assume this was ketoacidosis, right, with this blood sugar. So what happened? We gave volume, the metabolic acidosis. We don't have blood gases, but we assume the metabolic acidosis only improved a little bit, but we totally got rid of the anion gap. So what happened? Yeah, you just improved the GFR, and the anions came out in the urine. But it doesn't mean you've done anything to the ketoacidosis load. The patient still could be having the same magnitude of ketoacidosis. It just, you've masked the elevation in the blood now by causing them to be excreted, but you've done nothing to the production side. So don't think here that you've actually helped things. You might have, but you don't know with certitude. If you had someone with ESRT, this couldn't happen. The anion gap would stay the same. Unless you converted the organic anions to bicarbonate. That's a separate story. But if that was the case, this would have gone up by whatever the anion gap went down. So when you see the bicarbonate not changing, but the anion gap drops, you know that that's not a conversion of organic anions into new bicarbonate, right? Which is what you do when you give insulin. You actually take the carboxyl groups on acetoacetate and beta-hydroxybutyrate and turn them into bicarbonate. Here, you got rid of the anion gap by causing them to be teed up, which actually is a bad thing because the anions in an organic acidosis, whether it's lactate or beta-hydroxybutyrate or acetoacetate, are a good thing to have once you can convert them back into bicarbonate. Remember, it's not the organic anion that's causing the acid-base disorder, it's the proton that comes in with it. If you add sodium beta-hydroxybutyrate or potassium acetoacetate to the blood, you're not going to get a metabolic acidosis. You're just going to raise your anion gap. So it's the proton that's the problem here, not the organic anion. The organic anion is a good thing. In fact, we know that. We use lactate in peritoneal dialysis solutions to raise the bicarbonate. We get Scholl solution in RTA or different metabolic acidosis, sometimes in kids, to raise the bicarbonate. So it's the same thing with organic anions that are created endogenously. They're a good thing to have, and this patient will likely take longer to correct the metabolic acidosis. So remember, in ketoacidosis, the anion gap can be anything depending on how much is excreted. And in fact, people have shown that the lower the GFR, this is GFR, and this is anion gap. The anion gap varies with the GFR. As your GFR falls, the anion gap goes up for the same load. This is all a reflection of changes in excretion rate. So when you see these patients and you're assessing the anion gap, think of excretion rate also, not just on the production side like most people do. Okay. So here's another patient. So this is a 6-year-old with these numbers. Sodium is 138, potassium is 3.8, chloride is 90, total CO2 is 36, BUN is 13, the creatinine is 1.1, the pH is 7.29, the PCO2 is 72, and the calculated bicarbonate from the blood gas is 34, the PO2 is 50. And Ronchi were heard on chest exam. So what's the acid-base disorder here? Oh, I didn't give you the up rules. Okay, let me give you the up rules first. So if the bicarbonate is elevated, we have the same possibilities: metabolic alkalosis, acute respiratory acidosis, and chronic respiratory acidosis. So for metabolic alkalosis, the important point is there's also a compensation. People think of a compensation only for metabolic acidosis, except the PCO2 goes up. It's not quite 1-to-1, it's 0.7-to-1. So let's say your bicarbonate went from 25 to 35 because you started vomiting your lunch. Well, not your lunch. Let's say you vomited later. and your bicarbonate went from 25 to 35, your PCO2 would go up by 7. So if it started at 40, it should go to 47 if you're normal. So that's the compensation. It's not quite 1-to-1, it's 0.7-to-1. And again, unfortunately, asking why doesn't help here because it's all empirical. This is just the way our set points were set. And it crosses most species too. Acute respiratory acidosis, fortunately, is the same as acute respiratory alkalosis. For every 10 change in the PCO2, the bicarbonate changes by 1.5, except the directions are the opposite. So here we're dealing with an increase in the PCO2, the bicarb goes up by 1.5. And again, that's this reaction. This has nothing to do with organs. You don't need organs. You just have to increase this and you generate bicarbonate. Same as if you bubbled a bottle of water with carbon dioxide. But again, we find this temporal effect. So if we have the PCO2 here and we raise it, let's say from 40 to 50 and keep it there, we will find that the bicarbonate will go up acutely just from that reaction, but it'll continue to go up until a new steady state is reached after about 4 or 5 days or so. And that's what we call chronic respiratory acidosis. We don't have a name for in between. And again, that requires a kidney. So if you have ESRD, no matter how long you keep the PCO2 elevated, it'll always look acute. It will never generate that new bicarbonate and reclaim it. Okay, so you have to be careful because someone with ESRD can be comatose for 4 days, but their numbers always look acute because the kidney can't generate the new bicarbonate and reclaim it. It has to generate, the kidney here is generating it and reabsorbing that additional load. So you need normal kidney for that. So you have to be careful. These numbers for acute or for chronic respiratory acidosis and alkalosis assume not just temporal changes, but that the kidney is responding normally. Okay, so the question here is then, the bicarbonate is elevated, which, and again, you can use the 34 from the blood gases or 36. Notice the difference here is a little bit greater because now the difference is due to 0.03 times 72, which is around 2 point something. So you have to add that to this to get this, right? Anyway, let's look at the bicarbonate. So it's elevated. So what is it? Is it metabolic alkalosis compensated, acute respiratory acidosis, or chronic respiratory acidosis? This went up, let's say, by 9 or 10. So the bicarbonate changed roughly by 10. Oh, I didn't tell you what this was. So for the chronic respiratory acidosis, it's not 10 to 5. For every 10 increase in the PCO2, the bicarbonate increases a little bit more, such that there's a total of 3.5 change here. So it changes by another 2 chronically. Okay, so again, we just look at the changes. So the bicarbonate changed by 10, which is about 3 of these. So the PCO2 would have to go up by 30. People see that? Okay. And it did. I won't do the math for the others. So these numbers only fit this proportion, that for every 10 increase in the PCO2, the bicarbonate went up 3.5. Well, the bicarbonate went up 10, so this had to have gone up by 30 from the original. That's how we do it. So these numbers fit the chronic respiratory acidosis. And this patient had chronic bronchitis. You should also calculate the A gradient, which is to determine whether the drop in the PO2 was all due to a ventilatory problem or whether the patient had parenchymal lung disease, but we won't do that now. Okay, here's another patient. 58-year-old male with a bit of a drop in the sodium, hypokalemic, chloride 84, bicarbonate's 36, and there's some pre-renal failure probably. And the pH is 7.49. The PCO2 is 47, and the calculated bicarbonate is 35. So again, we have an elevated bicarbonate. It's either metabolic alkalosis or acute or chronic respiratory acidosis. So again, you just fit it into the 3 different expected proportions. So this changed by 10. So if it was chronic respiratory acidosis, the last patient, this would have to be 70, 71, 72, which it's not. So it can't be chronic respiratory acidosis. this would make this go up by 1.5. This went up by 10. The PCO2 would be in the 100. And you probably have a dead patient. So it's not that, and it's clearly 47. So just by default, if it's a pure acid-base disorder, it can only be metabolic alkalosis compensated, but you could prove it. This went up by 10, this went up by 7, right? So that is what you'd expect in a compensated metabolic alkalosis. So metabolic alkalosis, we divide up, not by anion gap, not by time, like we do with the respiratory acid-base disorders. We divide it up by what? Yeah, we divide it up therapeutically. Sort of a crazy subdivision. So we divide it up by a predicted response to therapy. And that's whether it's chloride sensitive or not chloride sensitive. And so how do we distinguish whether it is or isn't? There's no blood chemistry that we can use, but there's urine chemistry that we can use to make a prediction whether to give a chloride-containing salt or not give a chloride-containing salt, because there's some patients that you'll give as much chloride as you want to and nothing will happen. And there's another group you give the chloride and everything will return to normality, assuming that they're not still generating the problem. So how do we distinguish these two? We don't have anything in the urine to go by. Nothing fancy. Anybody know how you predict whether chloride will work or not? Otherwise, you have to give everybody the chloride. And that's a problem because some of these patients are hypertensive. You're going to be raising the blood pressure. Plus, you're wasting saline when it won't work. Yeah, we look at the urine chloride, and it turns out that empirically that if it's less than 15 or so milliequivalents per liter, when you look at a large population, they will respond. And if it's over that, they won't. The concept is that the patients that don't respond are in chloride balance. They're excreting their chloride intake like you and I are. So if they're on 100 milliequivalents of chloride a day and they're drinking a liter of water, the urine chloride will be 100. Obviously, the urine chloride depends on the water intake too, and in reality, we should be looking at the fractional excretion of chloride, which we never do, because obviously you can, if this patient drank half the water, this could go to 30 and you think it's chloride non-responsive. So really, in the ideal world, we'd be either measuring the timed collection of chloride, either 12 or 24 hour, whatever time you want, or a fractional excretion. But we don't. So you just have to always know, you know, when you see this, is two questions. Is my patient drinking a ton of water causing this? And in fact, the chloride excretion rate may be what their intake is. Or conversely, are they drinking very little water? And I'm making a chloride-sensitive patient look chloride resistant. So it's just, you have to keep that in the back of your mind. Or we should be looking at the chloride to creatinine ratio. But something to correct for the water intake, which we just don't do clinically. Just because most people are drinking a liter or two a day, so we don't have to think of it. But you want to keep that in your mind. So for this kind of metabolic alkalosis, this patient was under 15, and you'd give chloride and it would go away. For metabolic alkalosis, it's chloride. Well, for both, but especially for this, you have to think of two questions. One, where did the bicarbonate come from? And why isn't the kidney getting rid of it? Why isn't the kidney dumping it? Right? And especially the second question, even if you knew where it was coming from, if I simulate that by giving you a bicarbonate load, you just excrete it, right? It's very hard to keep someone's bicarbonate elevated. The kidney has a maximum absorption rate. If you exceed that, it just comes out. So why is this patient not excreting? If the patient does have a load, wherever the load is from, the second important question is, why is the kidney reabsorbing it all? So there's two abnormalities here that you have to figure out. You have to figure out the source, and you have to then ask, why is the kidney not able to get rid of it like a normal kidney can? And we call this the generation and the maintenance. So the generation in this patient is the parietal cell. So the parietal cell has a proton potassium ATPase. And this proton comes from all buffers in the cell, but the main one's carbonic acid bicarbonate. So every time a proton is secreted, you're generating a bicarbonate ion in the cell. Now, if this came out, this is the stomach, this is the lumen. If the bicarbonate went out this way, nothing would happen. You also wouldn't be acidifying your stomach. So it turns out that on the basolateral membrane is a chloride bicarbonate exchanger. And it's called AE2, anion exchanger 2, the protein. It's been known for 30 years or so. And every time a bicarbonate, so the bicarbonate leaves the cell in exchange for chloride, and this just goes to the gastric vein and then to your IVC. So every time you vomit, or when you eat, you generate bicarbonate that goes into the IVC. And so in vomiting, it's just excessive. So that's your load. It's no different than starting a bicarbonate IV. But there's something else that must be happening in that the kidney is not getting rid of it. And it turns out in vomiting, roughly 50% of the inability of the kidney to get rid of the load is because the GFR fell, because you're pre-renal. And if you could improve that, you would improve the excretion rate. And roughly 50% is because of increased reclamation, coupled with decreased secretion. It's complicated. The tubule also secretes bicarbonate in the collecting duct. So the proximal tubule actually increases its reclamation, and the collecting duct decreases its secretion. Turns out that secretion requires chloride in the lumen. Without chloride in the lumen, which these patients have, the secretion is very low. And when you give a chloride-containing salt back, whether it's sodium chloride, doesn't matter what the cation is, it's all chloride dependent. You improve the GFR and help them get rid of the bicarbonate. You shut off the proximal tubule from absorbing bicarbonate. That's neurogenic, probably sympathetic nerves from the volume depletion. And you enhance the collecting duct bicarbonate secretion, and that's how the bicarbonate returns to normal. So that's why giving a chloride-containing salt is important, and that sort of reflects on the centrality of thinking about the chloride in the urine. So we divide it up by whether the patients respond to chloride. Okay, here's I have a few more. We'll do one more, and if people want to continue and stay, I'd be glad to. So here's some more numbers. So this is a woman in the 3rd trimester of pregnancy. So we have a low total CO2 or bicarbonate. So we're dealing either with metabolic acidosis, anion gap elevation or normal, or acute or chronic respiratory alkalosis. So again, you look at the PCO2, look at the change from normality. Remember, her normal PCO2 is probably 37, 38, not 40. The bicarbonate, remember, is around 23. So look at the delta and see which of the three it fits. So which of the three? So this fell by maybe 9 or so, and this fell by maybe double that. So what of the three is it? Metabolic acidosis, they would have to be equal. So it can't be that. Acute respiratory alkalosis, it's 10 to 1.5, and certainly not that. It's roughly 2 to 1, right? The PCO2 fell, and the bicarbonate then fell about half that. That's chronic respiratory alkalosis. So this is what we see in the 3rd trimester of pregnancy, and it's probably from progesterone. But we also see this, at least in this hospital, with cirrhosis, and probably the most common on the planet, maybe not of this magnitude, would be people living at high altitude. So when someone comes into the ER in Denver, Colorado, they don't come in with numbers of 40 and 25. The whole population has a respiratory alkalosis. So that's what you're starting at. So they all start with an acid-base disorder, depending on the elevation. The important point is that not all drops in bicarbonate are due to metabolic acidosis. Okay, here's another one. 62-year-old with congestive heart failure. And here's the blood gases and the urine chloride, 80. patient was on Lasix. So again, we look at the bicarbonate, it's elevated, so it's either metabolic alkalosis or acute or chronic respiratory acidosis. And then we look at the PCO2, and works out that it's about 0.7 of what, 70% increase of what the bicarbonate went up. So it's compatible with metabolic alkalosis compensated. And the urine chloride is 80 because the patient was on Lasix. Now, the only point here is remember the diuretics can fall into either group. So the diuretic causes a metabolic alkalosis, but whether it's chloride sensitive or not depends on whether they're actively taking it or not. If they're actively taking it, then the urine chloride in the steady state is equal to their intake. Remember, the urine chloride only goes up for a few days on a diuretic, and then it returns right back to what it used to be. So they're in balance after a few days. So they will look chloride non-responsive, whereas if you stop the diuretic, the chloride goes very low, and then over a few days it comes back to normal again. So if you caught it here, so the urine chloride can be many things. When you first start it, it goes above normal. Then on the diuretic, it returns to normal. If you stop the diuretic, it goes below normal, and then comes back to normal. So here you'd say they're excreting more chloride than their intake. Here you'd say they're just in balance on the diuretic. Here you'd say they're chloride sensitive. And by here, they're back to normal. So remember that the urine chloride is dynamic on a diuretic, but don't simplistically think it's above normality. That's only in the first day or two. You don't keep getting negative balance on a diuretic. It only works for a few days and you go right back to the excretion rate you had before. Okay, I think we'll end with this one. This is a 25-year-old male with hypokalemia. Total CO2 is down, pH 7.32, PCO2 28, bicarbonate 14. So in the anion gap, okay, so well, first, these are roughly changed equally, so it's a compensated metabolic acidosis. Then we look at the anion gap. Anion gap's normal. So, you know, we're thinking GI problems, maybe RTA. But I'll tell you, historically, this patient was sniffing glue. So what does sniffing glue lead to? Yeah, and what does that then get metabolized to? Why does it cause a metabolic acidosis? Well, it's because hippuric acid is made, so a proton with hippurate. So that causes the metabolic acidosis, but then why isn't the anion gap elevated? Right, it should be no different than having proton with beta hydroxybutyrate, acetoacetate, or lactate, or whatever organic anion you want. Why do these patients tend to have a non-gap metabolic acidosis? Even if you didn't know anything, what would you conjecture? It can't be that it's metabolized to bicarbonate, but then they wouldn't have a metabolic acidosis, right? For instance, if you give someone a lactic acidosis, they get a proton load and a lactate load, and the lactate is converted to bicarbonate immediately from time zero, just like on PD. You'll never get the metabolic acidosis. The only reason we see a metabolic acidosis with lactic acidosis is that the proton lowers the bicarbonate fast, and the lactate is converted to bicarbonate very slowly. Okay? But what is occurring in these? Even if you didn't know anything, what would you guess? Why isn't the anion gap? There is hippurate generated for every proton. So what must be happening to the hippurate? Yeah, it's excreted. So in these patients, the kidney excretes hippurate very nicely. So you rarely see, you might see a little bit of elevation of the anion gap, but it's basically in the urine. Okay, so there are some clues that we have hippurate in the urine. One thing we tend to do is to look at the urine anion gap to assess the ammonia concentration. Remember, the urine anion gap is normally around -20 when we take the sodium minus chloride plus bicarbonate in the urine, or sodium plus potassium. We can include bicarbonate if we want, it's usually very low. But the answer is usually -20. If it's positive, we say there's ammonia in the urine. But here, these patients, or we have very little ammonia in the urine, excuse me. So this patient actually had an anion gap of +20. And you might say, well, there's very little ammonia in the urine. But you have to remember that the urine anion gap is equal to the urine anions minus the urine cations, in this case, ammonia. And so if you increase the urine anions, like in this patient with hippurate, a ton of hippurate, it'll actually raise your urine anion gap and make you think there's no ammonia in the urine. So that's an exam question they will always give you on your boards. They give you a patient like this, the anion gap's normal, the urine anion gap's positive, and everyone writes RTA, and it's wrong. So this patient had a proton low with an organic anion. The organic anion was excreted. Remember, organic anions in the urine make the anion gap positive, just like no ammonia does. It doesn't matter whether this number gets too low or this number gets too high. You're going to make it more positive. Well, there are other ways to figure out what the ammonia was. In this particular patient had a urine osmolar gap of 150. And that's a far better indirect assessment of the urine ammonia concentration at almost 50. So you take the difference, which is 100, and this patient, you divide by 2. So this patient had an ammonia concentration in the urine using this indirect assessment of around 50 millimolar, which is, pretty good. So so the urine, here's an example of a urine anion gap positive, but the urine osmolar gap tells you that it can't be due to a low ammonia. Anyway, it's a bit tricky and subtle, but I can explain that to people after if they want. But just the important teaching point here is, again, that you have an anion gap type of metabolic acidosis with very nice excretion of the organic anion, and therefore it looks hyperchloremic. It is hyperchloremic if you're using that word to define what the blood is, but the cause isn't hyperchloremic. So you have to always think of that subtlety when you're using the terminology. And also the subtlety of the urine anion gap when you have organic anions in the urine equally changes like ammonia does.
Do you get hypokalemia?
They do. And they do get hypokalemic, and one thought is that there's more negatively charged anions in the collecting duct causing enhanced K secretion. Not clear. That's a good point. Okay. I think we'll stop.